Hello. I am just waiting on my slides to be pulled up. But my name is Irene Brandt. I work across both the ARISE-NUTRINT and DASH, a little bit more heavily involved in DASH, and my main focus is in the mental health domain. And I'm with the Heidelberg University as well as Charité. But if you can't tell from my accent, I'm quite American. I'm not German. Just make it very clear. We're still waiting on the slides. Okay. I'm kind of tempted to rile up the room, start a party. How we all doing? No, okay. This is bad if I have a microphone. I mean, I could just start talking. Okay. We'll see how well I do without my slides. So a little bit of the structure of the projects. So for both ARISE-NUTRINT and DASH, there's a full surveillance questionnaire, very, very long questionnaire. And actually in both we cover multiple domains. So even though ARISE-NUTRINT is focused on nutrition, there's still a mental health section because obviously there's interesting things to investigate with nutrition behaviors that could connect with mental health. And in the wave 1 data collection, ARISE-NUTRINT was completed first. So the data I'm going to present is actually from ARISE-NUTRINT. So the mental health indicators I'm going to present on is from ARISE-NUTRINT, and it's specifically only for Tanzania. So I don't have all the cross countries, but it's in part just due to some other activities that had deadlines. We focused on Tanzania first. So that's one part of what I'll be talking about is some preliminary findings from that. And then another key aspect of the work that we did is a scoping review. And the scoping review really cuts across both domains. So that's the other aspect of research that I'll be talking about. Ah, there we are. Okay. Next slide, please. Okay. So in order to frame this, I mean, the really, really important thing about the surveillance questionnaire, and as I'm learning, and I'm not an expert in policy briefs, I've never taken a formal class on it. I get all my information from Joy. She teaches me on the spot. I'm a social psychologist, so that's my background, and experimental psychology. But one thing I've definitely learned from Joy is that it's really important to emphasize what is the actual problem so that there's a sense of action that needs to be taken. So that's why our surveillance questionnaire is super important because some of these measures have not been gathered in a while or not in this population or not with this age range. So just to have the information out there is essential to communicate to policymakers and decision makers that they should be paying attention, right? If you don't have the data, then how are you going to convince them that they should be paying attention? So we did this ARISE-NUTRINT surveillance questionnaire. It was a total of 1,410 people, ages 10 to 24, adolescents, and youth is what we call it as defined by WHO. And we're going to focus specifically, like I said, on mental health. The CAH-SSA site that this data was collected was in Dar es Salaam. And you can see a roughly equal distribution of males and females. You can go to the next slide. Okay, so from this first wave of data collection, we saw that 11% of adolescents and youth have depressive symptoms. And unfortunately, the infographic is not showing up well. That dark person is in a row of 10 individuals to kind of give you an indicate. So if you were to, and it's okay, I think it just doesn't show up because of the contrast of the screen. But this will be important actually for data visualization later. But just to give a sense, because when you say 11%, sometimes the mind just washes over. I mean, it's a number. But if you give the visual of, look around this room. Okay, so we have a group of 5 and we have a group of almost 5. Okay, one person out of these 2 tables is experiencing symptoms that would qualify for them maybe seeking help for depressive disorder. Then it gets put in context a bit more. Then you understand. 7% of adolescents and youth have anxiety symptoms, and almost 5% of adolescents and youth in this population have considered killing themselves once within the last year. You can see that the rates of depression and anxiety, they change quite a bit as the age progresses. And you know, there's a lot of quantitative data is great, but it doesn't tell us the whole story, right? So when you see these numbers, what I always think is what's happening in these dips? Like what is happening in this transition and this transition when you see a sharp increase, when you see a decline? What's happening? And I think that's actually a really great place to start, because you don't always have these questions to ask in your mind unless you collect the data, and then you want to know more, right? What's explaining this? And you can certainly theorize about what life transitions are happening, what developmental skills are being developed that might lead to these peaks and valleys. So in general, you can see, although there is a incline and decline, a general progression increasing with age, right, across the 2. And certainly for the older adolescents, they're at higher rates of both, right? When I summarized across the whole group, we have 11% depression, but if you look at these 23-year-olds, that's 20%, 1 of 5. So I go to this table, is there 5? No, there's 6. Go to this table, right? It's 1 now, 1, 1, 1, 1, 1. And then 13% for anxiety. You can go to the next slide. Okay, we also asked some questions about violence in Tanzania. So these questions were bound in the time frame of the last 6 months. So almost 15% of adolescents and youth experienced someone threatening to harm them. And almost 7% said they'd been beaten up so badly they were physically hurt and had to go get treated. You can go to the next slide. Okay, then substance use. So we looked at smoking, alcohol, and drug use, and we did drill into these with smoking on whether it was a cigarette or a vape. Alcohol, drugs, drilled into it a little bit, but overall, 13% of adolescents and youth reported having alcohol, about 8% reported having smoked, and 2%, a little less than 2%, reported having done drugs. Now this is important. This is just once in their entire life. Once. And the reason I put this graph up is I wanted you to see, so the visuals are missing as well, but so this one is for drugs. When we talk about the 2% of adolescents and youth who have done drugs, 100% of that 2% are males. Interesting, right? Very, very interesting. Why is it males? Why is it not females? What's going on there? For the smoking, 85% males. And then for the alcohol, 60% males. So you can see there's a bit of a gender trend happening here. Okay, you can go to the next slide. And here you can see by age, these 3 substance use categories. So alcohol, which you could gather from the previous slide, was the substance that was used the most by adolescents and youth in this population. You can also see, right, a very steady incline, and something's happening from 23 to 24, right? They are, I don't know, they're out of university, they're on their own, I'm not sure. And then you actually see a very similar trend happening for smoking. Now, you're starting at almost the same place, and you also see where you start branching out around the 16 to 17. So this is like a really interesting age as well to maybe focus on, like what is happening here, because the rates of use are quite low, as you can see in the younger years, and then you hit you know, this really interesting time where decisions start happening. Perhaps friend groups are forming. Your identity is being solidified. Are you someone who wants to hang out with a group of people who, if you want to be included, they like to smoke, right? And if you want to hang out with them and get invited again, you have to smoke, right? So I think there's really interesting things. Again, this is just the quantitative. But I think this is also a really great point to say we want to learn more, and can be used for decision makers, potential funders, policymakers to say, help us learn more, because this is showing something interesting here and we want to fully understand it. You can go to the next slide. Okay, so in summary, we have our statistics that I've pulled out like as potentially being useful if you were creating something like a policy brief or something like that. So that's a summary of that. I think next slide I'm going to be moving on to, yes, the scoping review. So the scoping review I think is also very, very informative. I'm probably talking to a group of people who already agree with me that you want to check the existing literature to see what solutions have been tried, especially if there was anything that might be relevant for your population of interest, the particular age range you're focused on, the country, the setting, and the context. So in DASH specifically, we're looking at mental health interventions that could be implemented by lay providers of some sort. Anyone basically who's not a mental health expert, and that could be in a lot of different forms. That could be a community health worker, that could be through a digital app, it could be through a brochure, it could be through a teacher, a parent. But basically we want to focus on any intervention that is meant to improve mental health that was not necessary for a mental health expert to deliver it. And the reason we want to focus on this within the population that we're working with in DASH in Sub-Saharan Africa, the ratio of available mental health professionals to population is extremely, extremely low. I mean, you know, in certain areas, there's 9 psychiatrists for the entire country. So if we want to not wait and subsequently build capacity for these mental health professionals, to train them, to build them up, to get more representation, but we also want to tackle the issue of mental health and make some improvements, then we thought it would be important to see what's been done in the past that might be effective and might be useful for our population. So here you can see this was our inclusion and exclusion criteria. We reviewed, and it wasn't just me, it was a group of like 10 to 15 different researchers on our team who reviewed over 28,000 articles that were initially passed through in the inclusion criteria. And we took 28,000 and we reduced it down to 28. So you're welcome, we did that for you. You don't have to do it again. And we're specifically focused on low and middle income countries. And we wiggled around with this eligibility criteria a bit because we wanted to focus in Sub-Saharan Africa, but we also wanted to make sure that our end of our inclusion studies wasn't so small that we couldn't find anything that might be useful. So we opened it up to low and middle income countries, thinking, you know, this might still, if we find a study that was done in India, in Nicaragua, Pakistan, maybe there is something that we could still glean that would be useful in our context. So you can go to the next slide. Okay, so I don't know where my visuals are. They were really great, and I'm the person talking about visuals later, so I just want to be clear that there was things there when I submitted it to Joy. It doesn't, we had little icons here. Okay, so what we found in the 28 studies that were included is it really depends on what the problem was defined, because when we made our inclusion criteria were very broad. We just said anything that focuses on improving mental health. So sometimes it was focused on, let's say, anxiety, and if it was focused on anxiety, then the methods would reflect that, right? So some interventions were learning how to do breathing exercises, so more mindfulness approach. Other exercises or interventions were group therapy, so talking to others about why you're stressed. Other interventions had to do more with take-home activities or in-school activities, so writing in a journal. So it really depended on what the outcomes were. Go ahead into the next slide. So here you can see and we tried to condense the 28 studies to these broad categories, but still we ended up with 10, so we didn't do such a great job. But you can see that in the studies that were included, we looked at several different things. So yes, depressive symptoms, well-being, anxiety, but then we have a set of other more, I would say, promotion or prevention, and not so much treatment. And that kind of colors the overall findings of the scoping review, is a lot of the interventions were more focused on the health promotion and prevention side. So building up life skills, really targeting things like socio-emotional skills, self-esteem, self-efficacy, some positive psychology, well-being. Now the bullying, physical violence, that was also preventative, but not necessarily the positive psychology side. And it went well beyond just talking about depression and anxiety, and it was much more on the side of trying to increase life skills. You can go to the next slide. Oh God, I don't know what happened to it. It's fine, it's not your fault back there. This is just what happens when you convert slides, I think, to Google. Okay, so, shoot. Well, okay. Here would have been a really lovely kind of visual chart of the different sort of skills that were being targeted in each of the interventions. And I wanted to, here in the shapes, which you can still see thankfully, are some examples of, like, actual examples of what the interventions were. So, like I said, there was a gratitude journal. So every day, the adolescents would write in it what they're grateful for. And this has had some showing of effectiveness in other countries, in other situations, in other contexts. Oh, thank you. Okay. There's also practicing problem solving, which was like a life skills course. Oh, see? I told you. I wasn't making it up. This is great to be justified here. Okay. So in the size of the box represents how many of the studies used interventions like this. So you could see there's positive life skills. So a good number of studies were focusing, like I said, on these building life skills through kind of a positive psychology. So the gratitude journal would definitely be part of that positive psychology train of thought. If we can build up things that make us thrive as humans, if we can strengthen the skills that give us strength and resilience, then we will be better equipped to handle mental health challenges. So that's kind of the thought behind it. Life skills like problem solving, role-playing, healthy communication, so these pro-social, like socio-emotional skills. And then, actually surprising to me, but maybe not so surprising, there was fewer of the CBT base. So this would be kind of like the traditional treatment method. If you are actually experiencing depression, anxiety, CBT is a usually therapist-delivered intervention, but there's certainly interventions being developed out there about how to deliver CBT through different avenues, not necessarily a trained therapist, but maybe a teacher. So there's a few studies on that. Learning about mental health, so this kind of building of literacy, mindfulness, and then I think there was one study on creative arts where they had dancing and kind of crafts and different artistic expressions. I might need help. Next slide. Okay. In general, we're also interested to see how long the intervention takes, because really, practically speaking, it's money, right? If it lasts for 6 months, once a week, it takes a lot of money. If you can deliver it once or twice, and it's quick, it's effective, and it moves the needle, that might be a little bit more appealing. And especially if we're starting in a context where there aren't a lot of mental health initiatives, sometimes there's not even policies about improving mental health, then it might be a little easier to sell a short time, one very cost-effective, low resource-intensive intervention, rather than trying to sell, let's build this into our school curriculum for an entire year. So we saw a range, basically on what the skill was that was the primary outcome, and kind of what the goal was for meeting that primary outcome. Sorry, next slide. Okay, what we saw, overwhelmingly, a lot of these interventions took place in school, which I think was one of the most interesting findings, because in DASH specifically, we are looking at at-home interventions. So that was really interesting to me, that we're kind of being quite innovative in our approach to think about how do we do this at home. Because previously, I think it's also interesting, when we cannot rely on mental health professionals, I find it very, very interesting that then we go to schools and we look to teachers. Because teachers are already there in place, they're often providing those socio-emotional skills already. So it makes sense that they're very natural and ready for the challenge group who can provide some support with the mental health learning as well. So yes, you can see teachers, a few online programs, a few lay providers, but the setting was generally in schools. And the most common, which makes sense if it's primarily teachers doing this intervention, primarily in schools, it was primarily group face-to-face, because if you think about a classroom, that's kind of the setting that you'd be in. We can go to the next slide. Okay, so in summary, when we looked at the scoping review of mental health interventions aimed to improve mental health outcomes delivered by people who are not mental health professionals in low and middle income countries, this is a nice summary slide. The programs, they did focus on helping depression and anxiety as well as teaching positive life skills. Typically, they lasted a few months. Typically, the programs were taught by teachers in group classes and taught by schools. That's what we saw. You can go to the next slide. I'm almost done. Okay, so that was helpful, but for DASH, like I said, we're thinking about at-home, one-on-one delivery, and we were also thinking about quick, almost costless, or at least low resource-intensive interventions. And so what we came up with is, what would it be if we could do the surveillance questionnaire and couple it with a quick intervention? And so for mental health, what we came up with is basically providing the adolescents with a comic book on mental health. And we thought a good place to start would be mental health literacy, and just start with kind of basic knowledge of the two most common disorders for a lot of the countries, which is, and in this population, which is anxiety and depression. So, like I said, our primary outcome was mental health literacy. We provided it at the time of the surveillance questionnaire. We actually did an RCT around it. I didn't want to get into that too much, but we compared it with a plain text flyer and a control group. And the preliminary outcomes are that it looks like we improved their literacy scores. So that's good news. And the reason I bring this up is because the scoping review, I think it was very helpful, but at the same time, it told us no one's really charted these territories before. And actually, mental health literacy, this data that we're collecting in DASH last year and this year, and we'll continue to collect, is the first time that mental health literacy has been collected in this population in these countries that we've been able to find. We found lots of qualitative studies about this, but not quantitative for Sub-Saharan Africa. So we're hoping to have actionable research to show that we're doing something that's innovative, and to think as much as possible what is going to be attractive to policymakers, to decision makers, when we're thinking especially of this setting where, like I said, there's not necessarily even an initiative around improving mental health. And our thought was, if we do something like this, that's very easy to integrate. This now exists. It's translated in all the local languages that are represented in our grant, and it's free, right? So if you came up to me and you said, this looks really cool, I think I would like to show it to my sister who's a principal at a secondary school. Okay, here you go, right? And we have good data to say that it's likely going to help improve literacy. So that's just a short snapshot of what we're doing in DASH, and my best attempt to try and connect it to policy. I'm sorry, I am not an expert in that, but hopefully you can fill in the gaps. Thank you so much for your time.
you so much. It's a very nice presentation. When I'm looking at this, I'm trying to connect the mental health and the accident. As we know, the highest adolescent and youth health affected is accident. That accident comes to the alcohol. And is there any relation between teenage pregnancy and mental health, like depression, if you have?
I am sure. We have the data. We need someone to look at it.
Could someone maybe give her a microphone? So I can hear the questions.
I heard your question, but maybe repeat it.
Okay. Oh, thank you so much. My question is not directly like a question, but I'm thinking about the mental health with alcohol. Most of the time, the adolescent is accident is the first in adolescent boys. That is why, because the alcohol is the consequence of the accident, or is like that one. Is there any relationship between teenage pregnancy or like child marriage, getting pregnancy, and the mental health? Like we know that depression is the consequence. If you, thank you.
Yeah. So in terms of the association between teenage pregnancy and mental health, like I said, you know, we have we have data. We just need time and resources to really look at it carefully, and also like look at different groups within it, right? Because it is very interesting to look at, well, how does economic status affect depression, anxiety, gender, whether or not someone has had a teenage pregnancy in and out of school. So we have the data, we're still working through it. Yeah, there's a lot to be done, a lot of work left. There was, yes. Oh.
Great presentation. I wanted to ask if any of those reviews included interventions that brought, multidisciplinary approach to including a particular intervention to improve mental health among adolescents. Bearing in mind that there could be cultural variations, and if we stick to just perhaps the psychological approach or type of intervention to improve mental health, it may not address some of the cultural issues and biological issues in those individuals. Did any of those reviews contain publications that included multidisciplinary approach?
Can you, so the question was if any of the interventions or the studies included in the scoping review used an interdisciplinary approach to develop the intervention. Probably some, I don't remember at this point. we had a, the frustrating thing is, so we had a column that reported on the design process. And I remember that column was mostly empty, which you assume then there wasn't a design process, right? There wasn't a lot of cultural adaptation, there wasn't a lot of engaging with stakeholders and multidisciplinary experts to develop that intervention. That's my assumption when they don't report it. Maybe the constraint for time, but I would say it was in the minority. Sometimes it did happen. And at least with, we're also working on another intervention that's a mental health curriculum that will be delivered over 2 home visits by community health workers that will hopefully be happening in the next year. But we've put a lot of thought into the design process and that, engaging adolescents themselves, engaging stakeholders, the parents, the community leaders, considering local adaptation, pilot testing again, and hopefully we will put that when we publish. So be very clear that our intervention was developed with multiple people who spoke into it.
My question is around social media. I am interested to know
the use of comic books, like what is the mode of delivery? Is it a book, like they will read, then they get informed from it? Because from where I understand, reading is, among this group of people, might be a bit boring. Have you considered another mode of delivery, like use of TikTok and Instagram, where they can be able to watch, not really reading, but they watch the information like you want to deliver to them so that they still get informed? Then another question still around social media, where you showed from the graph that the depression and anxiety level was decreased by age, but with smoking and use of drugs, the anxiety and depression, it increased by age, if I got it right. Okay, if both.
All increase with age. Basically, everything you go through
Okay.
life and everything's increasing. Your
Okay.
alcohol use, your depression, your anxiety. Yeah.
Okay, then my question is invalid. Thank you.
Yeah. Okay, so the first one, I'm trying to keep them. So social media, we had the same question. So in wave 2, we added a more extensive social media section to our questionnaire. So we don't have that data yet, but we will soon. Because we're also very curious how that impacted. So we asked a lot of questions around, do you have a phone? If you have the phone, what's the social media apps that you're using? How much time do you spend on those apps? And how difficult do you find to get off those apps, if I'm remembering all those questions correctly? So we'll have that data soon, because we agree it's likely very related. I mean, that's what we know from the other research that's been reported. And then the last thing, yes, the comic book, okay. So yes, we have many ideas for how to innovate it even more. The struggle that we have is we have some countries like South Africa who are very much have like a high penetration of cell phone use. There's a high percentage of the adolescents and youth that have access, that are on TikTok, that look at it. But then we have other countries like Uganda who said this is not something that our adolescent and youth are engaging with. They don't, if they have a phone, it's not a smartphone. And on their and if they have a smartphone, it's not representative of the full population. We're missing like a pretty good percentage that we could reach. So this is the tough thing, because we talk about implementing research in Sub-Saharan Africa, but these countries are all so different. And so, you know, what we thought is we'll do the comic book, and we'll do a hard copy first. And how we implemented, because it was part of the surveillance questionnaire, we had the community health worker read it out loud to the adolescent, but they had their own copy, and then they got to keep it. We do have many ideas, and to do a little bit of tailoring. So one idea is that for South Africa, who the use of smartphones is a little bit more ubiquitous among the population, doing a digital comic book, maybe some interactive elements or some audio elements as well. But then also thinking through other countries where we can be innovative and not necessarily be reliant on digital. But it's hard, because that's definitely a push to switch to digital intervention. So we're trying to do our best there. But yeah, good thoughts. Okay, I think I'm done. Thanks.